Positive end expiratory pressure, or PEEP, is a treatment that maintains airway pressure above atmospheric pressures. We all have a physiological intrinsic PEEP, and that is the positive pressure that we generate at the end of expiration, usually around 1 to 2 centimeters of water. Patients with airway obstruction can have a higher pathological intrinsic PEEP, and this can result in barotrauma. We commonly use PEEP for conditions like pulmonary edema, bronchiolitis, and most commonly sleep apnea, for which we give something called CPAP, continuous positive airway pressure, and that's a form of PEEP. So, how does it work? Let's imagine each alveoli, or alveolus, as a balloon. It takes a lot of effort to go from fully flat to partially inflated, but it then takes less effort to go from partially inflated to fully inflated. So if we plot that on the graph, the amount of effort it takes can look like this. A lot of the effort for patients who are ill and struggling with ventilation goes into that initial partial opening of each collapsed alveolus. Therefore, if we can help keep the airway partially open, we can significantly help with ventilation, and that's what PEEP does. So, if you look at the blue line, we're helping keeping it partially open, and therefore it's much easier for the patient. And again, you can see that in this graph. The blue, again, is the PEEP, and has a higher baseline pressure, so it's easier for the patient to then fully open their airways. It's important to note that PEEP can be achieved with any fraction of inhaled oxygen, from atmospheric at a concentration of about 21% all the way through to 100%, and this is dependent on a patient's specific requirement. How do we know if it's working? Well, again, we can look if they're needing a lot of oxygen, or is that oxygen requirement coming back down again? Have they got a reducing or increasing respiratory rate? Or do their oxygen saturations, are they changing as well? If they're on a ventilator, you might not be able to tell work of breathing or respiratory rate quite as easily, so instead you can look at a peak and a plateau pressure and the tidal volume and see if that's changing. Remember, oxygen is a drug, so it's important to consider indications for oxygen. Are they desaturating? Is that the reason why you need to give oxygen? And it's also important to consider, are they a chronic CO2 retainer? And in that case, you can see my other video on why oxygen in these patients might be harmful, but it comes down to these two effects, the Haldane effect and hypoxic pulmonary vasoconstriction.